So, yeah, welcome everyone to the first Global Sepsis Lecture of the year 2026. Um, Today we are really excited to welcome Dr. Vanessa Denny. She's attending physician in pediatric critical care in the Children's Hospital of Philadelphia. And she's also a global health researcher. Her work focuses on improving sepsis outcomes and strengthening critical care delivery in low and middle income countries through telemedicine, telesimulation, and novel approaches. Work was based for now in Ghana, where with the clinic she works with for example, in Kumasi. And yeah, she leads research and implementation efforts aimed to reducing global health disparities and advancing equitable critical care. She did also a lot of research on the barriers and facilitators for children with sepsis for seeking healthcare. So we are really excited to have you, Dr. Denny. And yeah, I give you the word and yeah, enjoy the session. Looking forward to it.
Thank you so much. Thank you everyone for having me. I will just go ahead and share my screen. Perfect. Is everyone able to see my screen okay?
Yeah, perfect.
Amazing. Thank you, everybody. It's an honor to be here just to talk with you about my collaborators and I's project that we've been working on for the past 2 years. The title of our project is Resuscitation, Education, Acute Care Help, and we use telemedicine with the goal to improve pediatric critical care in Ghana and throughout Sub-Saharan Africa. My colleagues are based out of Komfo-Noche Teaching Hospital in Kumasi, and then my mentors are also at the Children's Hospital Philadelphia. So as many of us know, there's a huge global challenge of septic shock throughout the world. My colleagues and I did an audit in Kumasi, and we found that there was more than 50% pediatric septic shock mortality and a morbidity rate. And a lot of these deaths were deemed preventable. A lot of these children presented late in their case. There's limited access to simulation and training, and there was a lot of gaps in early recognition and response to children who presented in septic shock. So my colleagues and I, under mentorship of Dr. John Appiah and Dr. Nakarni, and my co-lead, Jasisha Misa, and Dr. Princess Achia Pang from KNUST, we started out by doing a needs assessment where we really wanted to understand the barriers and the facilitators of children who come through the ED in septic shock as to why they can't be managed and prevented from dying. And so what we initially found from an outer setting, from a local national standpoint, there were a lot of barriers in terms of finances. There were a lot of referral delays from our referring hospitals. But things like the national insurance system was a factor that actually helped parents bring their children to the hospital. Individual characteristics that we found. There was a lot of fear among our caregivers and our children in coming to Komfo-Noche, which is our tertiary teaching hospital, a lot of spiritual and cultural beliefs that prevented them from seeking care, and then a lack of provider and caregiver knowledge on what it means when their child is ill. Things that helped them come to the hospital included just personal satisfaction and professional motivation from the clinicians. In terms of our inner setting, what we found, there was a lot of barriers in terms of like communications with the families. A lot of the clinicians and the nursing and the resident staff felt like they needed more training and education on managing sepsis and septic shock. Resource availability was an issue, staffing, and then their information management system. So what we did with this information, we really wanted to take one of these barriers and conduct a project where we could really target our interventions based off the needs of what our caregivers and our clinicians in our setting had described. And that was education and training. So through collaboration, we created a huge team. One of my mentors here, Dr. Appiah, who is the lead PI of this case in Ghana, and also the director of the PICU at Komfo-Noche, along with my co-lead, Jasisha Misa, and Dr. Owusu and Gustav, and then our qualitative team Dr. Chiapong, and then our Philadelphia-based collaborators, my mentor, Dr. Vinay Nakarni, Liz Senso, and Kyle Cassidy, and our partners in India, we all came together in order to create a platform that we could use in Ghana to help prevent mortality from pediatric septic shock. There's not have been a lot of studies that look at telesimulation low resource settings, but there were two big studies that looked at using a platform specifically trained for low cost telesimulation training in low resource settings. And we really wanted to contextualize this for Ghana. So we used a platform called Annenberg Hotkeys. And what we were able to do, we were able to take real life pictures with the caregiver's consent and video clips of children who present in different stages of septic shock and create a movie out of it and cause a simulation play by play. And we were able to train our providers using these cases. So what we hypothesized was that a contextualized remote telesimulation training program that was specifically for Kumasi would improve the number of time-critical interventions in simulated patients, but also in real patients, that it will improve our mortality outcome, and that it will be deemed acceptable and feasible by our clinicians. For the simulation participants, we included healthcare providers in the emergency department, which just included nurses, house officers, and residents, and we excluded any medical students. For the real patients, we really wanted to see if this telesimulation program had a positive outcome impact on the real patient outcome. And so we included children between the ages of 2 months to 14 years old, any child who presented with signs of shock, including poor perfusion, altered mental status, hypotension, and also with fever, tachycardia, respiratory distress, diarrhea, or diagnosis of malaria. And we excluded any children who were neonates, any child with sickle cell crisis or with severe anemia. Our study design was a mixed methods, prospective, quasi-experimental study design that we started out in just a single center. And we used 30-minute low bandwidth remote telesimulation training sessions that were contextualized to the Ghanaian environment using real live Ghanaian children. Our simulations assessed for 8 time-critical interventions, and then we did a 15-minute debrief after each session. After each session, the clinicians were able to fill out a survey to deem if this telesimulation platform was feasible and acceptable by them. So this is just a sample of what our simulation looked like. We would present a case with vitals. We would talk it through with the case. They would ask for a presentation of exam, and we would show a clip of the examination, and then it would be a play-by-play. So anything they asked for, we would have a video clip. If they wanted to know the capillary refill, we would have an image of a delayed or normal capillary refill time on a Ghanaian children. This is a checklist that we used during the simulation cases. There were a total of 8 checklist marks that they could get and 8 points. And every time they identified if the child was in shock, if they initiated oxygen, if they asked for IV access, got blood cultures, gave a fluid bolus, reassessed, and gave antibiotics, they would get a score. And this was the acceptability and feasibility checklist that they also completed at the end. So each group completed 2 simulations, and what we found was after the second simulation, there was a significant improvement in the completion of tasks. In terms of the acceptability and the feasibility and the surveys that we completed, more than 95% of the clinicians agreed that this program was easy to use, it was acceptable and feasible to use in their environment. So in terms of our real patients, we really want to see, after we trained our providers, how did this impact our children and how did it improve or not improve the clinical outcomes with these kids? So anytime a child presented with shock, they would undergo the Confinoche institutional screening criteria. We would track the baseline process of care, how long it took them to be assessed, the shock recognition, how long did it take them to get oxygen, IV access, fluid boluses, blood cultures, antibiotics, and what were their hemodynamics. We then did the telesimulation training for about 6 months. We then went back to track these processes of care for another 6 months. This was the checklist that we used for each child that presented during our study period in septic shock. Our dedicated nurses would write down the time they were seen at triage, the time they're seen by a nurse, the time the first assessment was done, if they got oxygen, IV access, etc., if they got fluid, how much fluid they got, and if it was a push-pull or ran over the pump. We also tracked their hemodynamics over a 3-hour time period. At the end of our study, we had a mixed demographics. The majority of our patients were younger pre-intervention. The median year was 1.4 years old, and post it was 4 years old. A majority of our patients came during the daytime hours. In terms of results, pre-intervention, 67% of our kids received oxygen, and this was significantly improved to 80% after our intervention. In terms of IV securement, 94% of our kids got IV access and actually got it faster, and this was significantly improved. Pre-intervention, 44% of the kids got IV fluid boluses, but only 84% of them were being reassessed after the IV bolus. But after the training session, less children got fluid boluses, but 100% of them were reassessed, and this was significantly different. And this was an improvement from our end. In terms of our outcomes, we did find that after the training, we had a significant improvement of our mortality. We went from 35% deaths of septic shock down to 10%. So there were a few limitations in our study. It was a non-randomized pre versus post study. There are some limited resources that we could not modify throughout the study. The simulation, we used the same case between sessions 1 and 2 for each clinician. And then the simulation population had majority physicians compared to nurses. And then there was a variable use of the local tree language during the training. So in conclusion, what we found over this 1.5-year study was that a contextualized remote telesimulation training for Kumasi, Ghana significantly improved the number of time-critical interventions in real and simulated patients. And although we didn't see a significant shock reversal improvement, we saw a very significant mortality rate improvement amongst our children who presented in shock through our ED in Kumasi, and that this simple tool was acceptable and feasible by our clinicians. So our vision for this platform is really to just create a sustainable and a scalable pediatric critical care training services in Ghana and throughout Sub-Saharan Africa. And we're hoping that this low bandwidth, easy tool can be used to help improve the outcomes for many pediatric critically ill children throughout the country. And I'll stop there.
Thank you so much, Vanessa. It was a wonderful session, and also I'm really impressed by the result you had in terms of improvement of of the quality. As you see in the quality indicator, there is a huge improvement, like time to fluid, time to antibiotics, and also for the mortality. So I'm really impressed, and I think it's a really promising procedure. And yes, I'm happy to have maybe question from anyone. You can ask your question in the chat to Dr. Denny, or you can just unmute yourself. Yes, please. Welcome.
Hi, Dr. Denny, Dr. Vanessa. Okay,
Hello.
This is Halima. So I'm sorry I joined a bit late, so I didn't hear much of the presentation from the beginning. Yeah, but I can see that there was quite a huge improvement, especially in the mortality rate. So you had an app that you created, and you demonstrated the use at the bedside, right?
Yeah, so it's a platform that we use that the University of Pennsylvania developed, and basically you can embed real live videos of children in any context that you like. And so what we wanted to do differently was ensure that our simulated cases look like the children that we're treating, and that was in a familiar environment. So for us and for me and my colleagues, it was important that we had cases that looked like the Ghanaian children who the providers that we were trying to train, looked like that in the simulation platform, and that they were being trained in the same environment. So all the clips we took were children who came in through the emergency room or the ICU. And so all the resources, all the tools that they used was a familiar setting. And then we embedded it into the platform.
Oh, great. So what about the antibiotic issue about this, culture? Blood culture takes so long, Did you have any challenges, giving your antibiotic early enough?
Yeah, we did. So we actually had multiple challenges. So one of the issues we have at Confinoche, and my partner, Dr. Misa, is also on the line, is sometimes we don't have the blood culture bottles. So we would not be able to get the cultures in a timely fashion, which skewed some of the results, but that's just reality. And so we wanted it to reflect what actually was happening in our health system. So it was nice for us to actually see the length of time it was taking for some children to get cultures and to get antibiotics.
Yeah, and then lastly, about the cost, was there any cost, because most of these patients, pay out of pocket. So was there any extra cost, cost to what, you used for the
Yeah, so the
patient?
great thing, so this platform is completely free. So the training for the clinicians, it had no cost to them, no cost to the families, which is why we love this platform. And it's really low bandwidth, so you didn't need like strong Wi-Fi to use it. Obviously, there's costs for each child that comes through the hospital, and we didn't want to alter what realistically happens at Confinoche. And in one of our needs assessment, we found that one of the huge barriers for families is cost in coming to the hospital. And so that's another issue that can also be addressed in future studies, was just the cost effectiveness.
Yeah, thank you so much. So
Of
see
course.
you.
Yes, thank you so much. Thank you for joining.
Yeah.
So, Dr. Nadkarni, you've raised your hand. Wanted to
Yeah, it was very interesting. I think that the resolution of shock didn't significantly improve, and that fewer children actually got fluid boluses. They had
Mhm.
IVs, but they got fluid boluses. And I think that might reflect that the training that you did kind of right-sized, made them evaluate more and judiciously use fluid when appropriate and give fluid when appropriate. So I think it's not that surprising that they got less fluid, but I think the importance was that you're training. Some of your importance is that you train them to really think and do, and not just follow a protocol that was one size fits all.
Exactly. A lot of our debrief was around fluid, and how to be careful with giving fluid, the importance of reassessment. And if you're in an environment that has a limited amount of ventilators, if your child becomes fluid overloaded, that you need to be very careful in the amount of fluid that you're giving each child that comes in shock.
Also, Dr. Nadkarni, you just made a commentary that the Simbox is the ACP platform adapted to hotkeys, engage learners and make it more realistic to the context of care. Yeah, thank you. Anyone else has a question? Yes, Charles, welcome. Can unmute yourself.
Hi, Elena. Hi, Vanessa. Hi,
Hi,
Vinay.
Charles.
Yeah, so I'm a little biased because I'm in Confanoche, but I wondered during your needs assessment, whether beyond the requirements for like the various in and outer factors, was training what was most significantly required? I asked because Helena and I have been interested in digital health tools and technologies that could help improve sepsis outcomes and quality of care. So I wondered whether beyond the training needs, especially because we were in a teaching hospital setting, did you see any other factors that there were possible low-cost opportunities to intervene? Thank you.
Yeah, that's a great question. And I'm happy to share the paper with you, but there was a lot that came out through the needs assessment. One of the main barriers that the clinicians expressed was just getting time to study and to be educated. They're just so busy, as you know, Charles. It's hard for them to have dedicated time to just learn. Another thing was just the low manpower and the amount of children that they're treating on a daily basis was another issue. But the main modifiable thing that we came to that was highlighted was just the lack of education and the need for more tangible simulation. And so we found that this platform was so easy to use, and we were able to contextualize it specifically to Ghana, that it was something that they could use on their own even after the study period, and that it could be replicated in very similar environments, throughout the world.
Thank you so much. I mean to commend you because, and I've always liked the practical presentations of these studies rather than, tutorials saying these are gold standards and this is what you should do. But this hasn't just identified a problem, has actually recommended solutions and actually tried it out. And hopefully that can be replicated elsewhere. So thank you very much for this presentation.
Thank you, Charles.
Thank you, Charles. Any other questions, commentaries? Okay. Maybe I have a question. Do you think that telesimulation could be also applicable for healthcare workers outside of the hospital? That could be doable, for example, for maybe smaller healthcare center that are not in bigger hospital, or maybe for community healthcare workers that are not trained in the hospital for early recognition?
Definitely, and I think that should be one of the next steps is targeting the referral hospitals, the small community hospitals where often these children present first. And being able to train them, I think, will have a downstream effect in, preserving more lives by the time they get to Confinoche. So one of our next studies that we're hoping to collaborate with you is using telemedicine to expand critical care to these distant rural hospitals that refer their children to Confinoche, and see if we can help them resuscitate children earlier and faster prior to transporting them to the teaching hospital.
Yeah, thank you. We would be happy to collaborate for sure. Okay. Maybe Dr. Nadkarni just made a commentary. Justicia, I hope I pronounced it well. Can you comment whether such trainings are continued, sustained beyond study that we have done? Don't know if this person is online.
Yes, we started, but at a point we went on a break. I had exams and all that, so we are yet to pick up again and sustain it this time around.
Great, thank you. Okay.
And yes, I just saw Dr. Carney's comment. We are looking to expand this to Enugu, Nigeria, with Dr. Adira, who's a pediatric intensivist. So we'll be also trialing this in Nigeria as well.
That would be great. I know Dr. Adira, yes.
You know him.
Yes, of course, yes. That would be great. Thank you, Dr. Vina. Thank you so much. That would be great.
Great. Okay. Any other commentaries, questions? So thank you, Dr. Nadkarni. You sent also the link from the Simbox, so I will send it to the participants. Thank you so much.
Yes, and you'll see that that's the generic Simbox. And so like with white, you'll see that the YouTube videos on that neonatal sepsis example may not look like the children in Africa, may not look like the children that you're actually taking care of. And that what Vanessa and the group at UPenn did was that they, with our Ghanaian counterparts, was they contextualized it so that the children look and feel, and the resuscitation bay looks and feels like the real resuscitation bay that they work in. And I think that's the difference between a one-size-fits-all Telesimbox and then this contextualized version that they piloted that was so successful in saving lives.
Great, great. That's awesome. That's awesome.
Perfect. Thank you. Yeah, just a quick news for the webinar. We'll now send e-certificates to the participants. So everyone who has participated will get a certificate. That's quite new for 2026. Okay.
That's wonderful. Thank you.
Thank you so much. Dr. Denny, thank you so much for the work you've done and for presenting your work. And yeah, looking forward to see you, not only online.
Thank you so much. I appreciate it. We'll be in touch.
We'll keep in touch. See you.
Okay, take care, everybody.
Take care. Bye.
Bye.